Hi, my name's Maria and I'm a speech pathologist at St Vincent's Hospital in Sydney. I'm a clinical educator and I've actually been in that position for over 11 years. My workplace setting is a subacute inpatient setting at a metropolitan hospital in Sydney, St Vincent's Hospital, and the types of patients that I see that make up my caseload are predominantly of neurological etiology, mostly strokes, but sometimes degenerative conditions such as multiple sclerosis or Parkinson's disease. We also see some patients who have had brain tumours resected, or as well patients who've been in hospital for a long period of time. They've had very complex medical issues and they've been in hospital a long period of time and are quite deconditioned. Students who are at entry level will consult their clinical educator if there's a complex issue or something that they want to discuss further, and that's really valuable and broaches on more of an intercollegial relationship. Students at the intermediate level require more moderate amounts of supervision, so they have some idea of their actions and plans but just might need a bit of assistance to refine where their thinking is going. They require more time to get tasks completed. For example, if they've got an assessment or a therapy plan, it will take them longer to go through the assessment and be prepared for that. With an intermediate student and completing a dysphagia assessment, I find that they need more guidance. Often they haven't, had an opportunity to do it before, so they need to have their hand held a little bit with going through what to do in a cranial nerve assessment or a motor assessment, and also more information about the stages of swallowing to look out for and what kind of observations to make. Often, they're able to give the patient the food, but they're not really sure of the key observations that they're to be making. So for example, the amount of time that it might take for a patient to chew up their food, whether there's residue in their mouth or looking at detail of oral spillage. They need more assistance with bringing that all together. They'll make some pertinent observations, of course, but they just need more support with bringing it all together and the more finer kinds of observations. I have a template for a swallowing evaluation, and I find that a really useful tool. However, I find it best if the student has a go first at doing the assessment, and after the assessment, when we're going through it, then actually use the template afterwards. And I find that gives them a real point of reference for making their observations. Well, at the point of entry level for a dysphagia assessment, before the students come to the placement, I actually suggest that they come feeling prepared to be able to do a cranial nerve assessment, a neuromotor assessment at short notice, because I want them to come to the placement having something up their sleeve that they can do at short notice. So I do send them some pre-placement readings about doing that as well. And when they come to placement, then I expect that they're able to have a go at doing a cranial nerve assessment and do quite a reasonable job. Maybe they might need a bit of guidance with refining something that you do in your setting that they may not have been necessarily required to do at a previous setting, but that's all fine. And they have an idea about how they'd go about a dysphagia assessment, what sort of food to prepare, also what sort of observations to make. And at the end of placement, when they are at entry level, they're able to do that fairly seamlessly, unless it's a complex patient, but they're able to do a cranial nerve assessment competently, and they're able to make observations on the oral and pharyngeal stages of the swallow, and also draw conclusions from that for the management of that patient. So another example of an intermediate student with actually conducting therapy is they'll be able to come up with a plan for the session, and they may need some tweaking with your input as the clinical educator before running the session, but they're able to go forward and run the session. However, they might need some more help with refining their recording of objective data, knowing exactly what kind of data they are collecting, and also refining their cues that they use to assist people to produce their responses. An entry-level student will be able to go into a therapy session, especially with a client that they know quite well, and know exactly what kind of data they're going to be collecting, be clear about the goals of the session, and also be clear about their feedback, so how they're going about teaching on error and what sort of cueing hierarchy that they'll be using. So with an entry-level student, I find that their approach is more holistic, they're more patient-centred, they're thinking about the patient's family and relatives, they're thinking about other team members on the team and how they might be interacting with their particular client. I also find entry-level students need much less direct supervision. They're more independent. They're not totally independent, but they are largely independent. They can run a session themselves, especially with a patient that they know quite well, and have that run really quite smoothly. I love it when students are thinking about their patients more responsibly, so they're taking more full responsibility for the patient, which really is related to thinking of the patient as their own, rather than they're just running a session but the patient really is their clinical educator's patient and they've just got to do a good job with the patient. So they're taking more responsibility, they're thinking about the discharge planning of that particular patient, they're thinking about their family, they're thinking about that particular patient's goals, and they're not just thinking about the therapy task for their patients, but they're thinking wider than that, about how this person is going to communicate, who this patient will communicate with and how they can facilitate that. I communicate competency expectations to students through discussion and debriefing, and also looking at the compass as well. It provides really useful examples. We also talk about the CBOS document because that has some great examples in it that are practical for students to refer to. With the students and discussing their competencies, I like to try and keep an open communication dialogue, an intercollegial relationship, so they feel comfortable and not like they're being assessed all the time, so that the relationship is most useful for their learning. I find communicating about competencies is also helpful with their self-reflections. The students do a weekly self-reflection, and I find that that provides a good discussion point and also an opportunity for some written feedback about where they're going and where they need to be to reach competency.